Dr. Trent Haywood is a physician who completed his medical training at the University of Illinois. He's an attorney who earned his JD from Northwestern University. He spent 6 years as the Deputy Chief Medical Officer at the Centers for Medicare and Medicaid Services, and another 7 as the Chief Medical Officer at Blue Cross Blue Shield Association. In addition, Dr. Haywood has co-founded a company, served on the Board of Governors for the Patient-Centered Outcome Research Institute, and as a board member for the YMCA and on the Medical Advisory Board for Teledoc. Today, he's the head of a product innovation at Mindshift and the founder of Novelty, which advises healthcare startups. We are delighted to welcome the very talented Dr. Trent Haywood to Chet Talks. Trent, welcome. Maybe just unmute your mic there, Trent.
Can you hear me now? Can you hear me, Ray?
Yes, perfect. Thanks for joining us, Trent.
Well, it's my pleasure to be with you this afternoon. I'm looking forward to the conversation. It's just an exciting time in healthcare, as you're well aware of. It's unprecedented, to say the least.
Well, let's start our conversation with digital health. Funding for digital health set a record in the first half of this year. 2 companies, Amwell and GoodRx, have recently filed to go public. You advise healthcare startups. What are you seeing?
Well, the reality is I think digital health is going to just continue to accelerate. When you look at some of the forecasts, it's already forecasting just CAGR growth of 20% and above is what you're seeing. Some are forecasting that globally by 2025, we'll be at $350 billion market size alone, which means you're fastly approaching within this decade close to probably $1 trillion market size. So I just see digital health just continue to expand. And I'm excited and obviously bullish on digital health.
350 billion by 2025?
Yes.
So that'd be about, it's more than 1/10 of the entire healthcare sector, which is about 3 trillion in the United States currently.
Right, now that's global, but yes, you're correct. It'll be the equivalent of 10% of what we're spending here in the United States. And it's kind of that old software eats everybody's lunch type thing. I think that's what we're seeing occurring in digital health.
You said you're bullish. Where do you see the biggest opportunities?
Well, it's multifaceted. I think you're starting to see providers, because of what's taking place in COVID, finally being able to see the impact and the benefit. And so now we have providers on board. Previously, obviously, consumers are already doing digital health and looking for digital health solutions. And then you're starting to see innovative companies that traditionally weren't in healthcare, recognizing that $3 trillion market size that you were just alluding to and saying, hey, that seems like a nice market to be able to take our technology and our innovation and go into that market. So I think from all aspects, the consumers, the providers, and then of course the technology companies saying it makes sense to be able to get into digital health.
So last week we spoke with Robert Califf, who heads a medical strategy for Alphabet, and one of those technology companies that's making substantial investments in digital health, including a $100 million investment in Amwell announced last week. You focus, I think, on smaller digital health companies. Can you tell us a little bit about who your clients are and what they're trying to do?
Sure, and I appreciate, I've had the opportunity to host Rob Califf when I was the Chief Medical Officer. So it's great to be able to follow Rob on Chet Talks. The short of it is, you're correct. I'm starting off with either seed or, A or B round a company, so much smaller than Alphabet, obviously. And the reason why I think there's just a lot of opportunities to be able to have an impact. And so my goal was to be able to help accelerate market adoption from these particular companies with the ultimate outcome 3 to 4 years down the road. We see the impact that we want for the average American consumer, if you will. So for example, one company called Patient, Paytiant, is focusing on medical debt and how we can leverage technology to be able to help create situations that's great for the provider, because the provider is not necessarily worried about suddenly having to sue their patient and being able to create issues for that patient-provider relationship. But on the other hand, making certain the patients aren't feeling like they're suddenly having to ruin their credit to be able to satisfy the needs of the healthcare costs. And so they're using technology in a nice way to be able to smooth that out and create payments and payment plans Another one of the companies I work with called Uno Health, they're looking at being able to leverage technology, saying what we're seeing, particularly on the Medicare Advantage, but also on the Medicaid side, is that there's opportunities to be able to, in this particular environment, obviously with the pandemic, really help people put money in their pockets so that they can actually survive this pandemic environment. And so they're using technology in a nice way to be able to say, we recognize there's a lot of under-enrollment. It's amazing how many people are under-enrolled in these government programs. It's almost like a turbo tax for healthcare where they're being able to leverage the technology that they created, streamline that whole process. And what they're seeing, Ray, is that on average, they're probably getting $5,000 in benefits on an annual basis for these individuals, as well as on another $1,500 per beneficiary or per member that goes back to the plan. So substantial amount of dollars. And I say to everyone, this is as close as that you've ever gotten to the proverbial, it cures cancer, it tastes like chocolate, and it costs a penny. I mean, that's literally what you're doing with the model that Uno Health has. So I love what they're doing with that particular model. There's another company, Tomorrow Health. What they recognize is that traditionally, as it relates to this whole movement in towards home-based care strategies, and recognizing, I know on some of your former guests, they talked about the realities that we're moving outside the four walls of the hospital setting and back into the home setting. And so they recognize that most payers don't really have a great home-based care strategy. And instead, what they've traditionally done is looked at durable medical equipment, and they look at that as a commodity and not really see that as a strategic play. And so Tomorrow Health has come along again, leveraging technology. One of the co-founders was from Casper, and he's the CTO from Casper, if you guys are familiar with Casper Mattress, and has a great approach to direct to consumer and being able to do that successfully. They brought that same model into healthcare now, and they're taking over the opportunity to be able to revolutionize DME. And the last one for now that I'll mention is January AI on the diabetes side. And what January AI has come along and doing is taking advantage of a lot of the recent literature that says, you know, when you talk about being a type 2 diabetic, it doesn't really say what that means for a Ray or a Trent if we happen to have type 2 diabetes, because what the literature is showing is that each one of us can eat the same exact meal and respond to it differently. And so you need artificial intelligence to be able to personalize your care path for you. And it's about self-care and self-management. And so they're using that digital technology on the mobile platform, providing you that information. You can take a photo of the tea that you might be drinking this morning or the sandwich that you might be having, and it automatically uploads the information, tell you what the glucose load is and glycemic index and how it relates to your nutrition and your fitness. And so we see a lot of that's going to happen in the next decade by condition, whether it be diabetes with January AI or whether it be heart failure and some others. All of that is going to be under the umbrella of digital health.
So I know our listeners were going to ask you some questions about some of these companies. Let me take them one at a time. Patient. I don't think most people realize that healthcare debt is one of the leading causes of bankruptcy in this country.
Absolutely. And I know I've had personal family stories where they've had to make significant choices related to which family member in that particular house is going to be able to afford the medications that they need. And so these are really tough decisions that a lot of Americans are making. And when they went and looked at the literature, what they saw was in a lot of situations, they could potentially afford it, but they need to be able to smooth out the payments over a longer period of time instead of having this emergency situation that wasn't necessarily anticipated. And so they've done a great job coming along and being able to work with the employers to be able to do payroll deductions, allow the individual patient to decide, do you want to pay that over 6 months? Do you want to pay it over 12 months? How do you want to structure it? And no interest fees and anything of that nature, no reporting you to the credit card, so you're not having that particular fear. So I think you're going to hear much more about patient as we get into 2021.
I think I'm challenging nonprofits, you know, tax exempt status, maybe to think about their own practices themselves.
Yeah.
Second one, you know, health cures cancers, tastes like chocolate, and costs a penny. That's not bad. One thing I guess is I think 12 to 15 million Americans uninsured, unemployed now, a record number of unemployment in the setting of the pandemic. Mississippi, I think, just recently announced expansion of Medicaid. One of my colleagues reports that 90 million people might be enrolled in Medicaid coming out of this COVID pandemic. Does that mean a lot of work for Health?
Well, they started off on Medicare Advantage side is where they started. There's another company that I work with that's actually going more towards Medicaid, and they're called Plentify, and they are taking advantage of technology, but they're doing it in a different way. And what they're doing is saying, listen, what we probably have overlooked is like for federally qualified health centers as well as individual practitioners that are serving the underserved. So primarily their largest payer is Medicaid. Is that we think we can do value-based arrangement in a way that actually leads to financial stability for these practices. And we saw that in fee-for-service, where now suddenly we're recognizing that you're not able to generate the revenue that you traditionally would have been able to generate because people aren't necessarily able to come into the office. So it would have been much better if you were in a capitated model or a partially capitated model. But the barrier has been for a lot of these practices that the technology barrier has been a big one. So Plentify now has come along and saying, why don't we end up spreading that unit cost over a much broader population of providers and going after all the federally qualified health centers and the medically underserved areas. And so that's where we see kind of for my portfolio, the biggest one is going to be Plentify, going after these providers that are predominantly dependent upon Medicaid, but also taking advantage of the commercial value-based arrangements.
Tomorrow Health sounds like it's building on the work of Dr. Bruce Leff, one of our previous guests, geriatrician Johns Hopkins created this hospital at home model. We know one of the big challenges with the COVID pandemic is trying to keep people out of the hospital so we minimize the risk of spread from patient to healthcare workers, and then to the broader community. Is Tomorrow Health doing anything on enabling people with COVID to receive care at their home without coming to institutions?
Yeah, absolutely. In fact, the mayor for New York City, Mayor de Blasio, they had recognized Tomorrow Health as their preferred strategic partner in New York City to address that specific issue, Ray. And they're continuing to leverage that broadly now, going beyond New York City with that particular model. One of the founders had personal experiences with that specific issue when his own mother was dealing with those particular issues, trying to keep her out of the hospital. And one of the biggest concerns was that it just wasn't coordinated. It was very fragmented care. And so he suddenly was stepping in to be kind of the caregiver that's required instead of the relationship that the payer should have had and been able to manage that all. And so with the value proposition for a lot of the payers that they're talking to is that suddenly it's no longer fragmented, it's coordinated, it's designed to be able to reduce any readmissions back into the hospital, and it has really high net promoter scores. Most of the time they're above 95. So as you can imagine in healthcare, we normally are jumping up and down if we get anywhere near 70, right? And they've taken the fact that the other co-founder, came from a direct-to-consumer model where it was incumbent for you to have those type of consumer engagements. And so they're doing a fabulous job, and they're going to continue to grow and have that value proposition of reducing the need to be able to go back into the hospital setting.
You talked about readmissions. Can you talk about preventing admissions in the first place? Are they doing anything specific for COVID? Are they doing anything about monitoring people's pulse oximetry at home, providing nursing care to them, remote monitoring?
Yeah, so they do. I'm glad you mentioned that. They do have actually patient care advisors that are getting on the phone, kind of similar to some of your other guests. It's not necessarily considered to be virtual care, so they're not billing for virtual care, but they are providing that care support, checking in on those particular members, trying to identify, and to your point, being even proactive. So oftentimes what happens in that particular space is that someone like a physician might order a particular supply for the home setting, and then come to find out the patient doesn't necessarily vocalize that they're having problems with that particular supply, that it's not necessarily meeting that particular patient's need. Well, because they have those patient care advisors checking in on those individuals and making certain that they're getting what they need. To your point, they're being very proactive and preventing any need for them to be able to ever go into the hospital setting.
Last company mentioned is January AI, focusing on artificial intelligence for diabetes, which leads us to Lee Shapiro, recent guest on Chet Talk, the Chief Financial Officer of Livongo, recently announced this merger with Teledoc. You serve on the medical advisory board of Teledoc. What are your thoughts on the merger?
Yeah, and so let me give my thoughts, but let me, because I'm also an attorney, as you mentioned. So let me give the attorney disclaimer that most people do, right? Which is, I serve on the advisory board of Teledoc, but they're a publicly traded company, and so I don't want to suggest that I have any information that the rest of the public wouldn't have. So this is just Trent Haywood's opinion. I think it's a fascinating opportunity, even pre-merger with Livongo. And so I know Glenn and Lee, and obviously I know Jason and that team as well. And I know you, apparently Lee talked a little bit about the realities of being kind of the leading kind of global healthcare company. I think they're well on their way, without a doubt. They're already a global company. They're well on their way. In fact, I think a lot of people are still not fully realizing how impactful telehealth is about to become. So I was talking to some colleagues at A16Z about this, and I said, you have to go back and, there's books that you can read about platform wars, right, on the technology side, and why, suddenly, people talk about the reason why Google and Apple had that falling out, and why Google felt like it was critically important at that particular time to have their own phone, right, instead of being dependent upon the Apple iPhone. I think what you're going to see as we look back, as we get to 2030 and look back, suddenly the telehealth platform in and of itself is going to become much more dominant and much more the platform that starts to dictate the way in which we want to be able to avail ourselves of services, because consumers are already there. Consumers have strong engagement with the telehealth platforms. A lot of physicians look at that opportunity as a better way to be able to deliver some of the services that they want to deliver outside the traditional outpatient clinic setting. And so you have providers quickly realizing in this COVID environment, not post-COVID, in this COVID environment, that they actually are benefiting from that particular arrangement. And so suddenly with the other additional aspects of telehealth starting to go beyond just acute setting and get into primary care and chronic conditions, I think people are miscalculating how impactful the change in telehealth is, and that a lot of us are certainly going to treat it similar to how we think about, are you on an Android operating system or are you on an Apple operating system? I think that's where we're headed with telehealth, and that's how impactful it's going to be.
So miscalculating, underestimating platform wars. Let's dive a little deeper. So can I just use Zoom as a platform to provide, to connect to patients? Does it really matter what the platform is? Am I missing something?
Yeah, a great point for all of us that's probably been in this environment. We're jumping around on so many different ones that we're starting to firsthand experience the differences in the platforms. I think with healthcare, it's obviously fundamentally different. And from the beginning, these companies are designed to natively focus on healthcare and the delivery of healthcare and the specifics around healthcare, because right now, like this Zoom, before we jumped on this Zoom call, I wasn't worried about whether it was high trust certified or not. I wasn't worried about whether it was encrypted or not. You asked me to jump on, I'm there with you, Ray. It was that simple, right? Or that's not the reality, as you well know. Once you get into healthcare, it's a fundamentally different game. I was fortunate enough when I was at Blue Cross Blue Shield Association to do the first deal with Lyft. And so we had a great opportunity to do transportation with Lyft. But when they got into healthcare, they realized it was a fundamentally different game. There's a lot of regulation that goes on to it, into it. And so it takes a lot of experience and time to be able to successfully do that in healthcare. So I think that's where you get some of the barriers to entry and why some of these pioneers are going to continue to accelerate and be ahead of others. And then for the other innovative companies that come along, it's going to be easier for them to go ahead and jump onto that platform that is already existing as the incumbent than trying to recreate that platform on their own.
So I'll be provocative. Who loses as digital? Who loses?
Yeah. Here's the reality, and it's funny that you said you'd be provocative, because I've been in that same situation where I would tell people, I show them this whole analogy related to the record industry, right? And how we used to all go to the record store, and now, unless you're looking for vintage records or something like that, no one's running out to the record store. And everybody in healthcare would love the analogy, but no one would actually say, who's the record store, right, in that analogy. So you're asking me, I'm going to be blunt and honest. I think the reason why it took so long for us to get this particular adoption, meaning other than the pandemic, we probably would have been trickling along. It would have grown, but it would probably taken another decade, is because we hadn't figured out the reality is that I think large infrastructure plays that have like high capital expenditures, and you know that means large providers and large facilities that are used to having facility fees are the losers in this, without a doubt, because they're trying to figure out how do I deal with that. If you're the CFO of a large hospital or health system, you're trying to figure out if no one is coming in to fill those beds and you just built a large outpatient facility as well, there's no need for that either. Consumers, like I'm in downtown Chicago and we have some great, marquee provider health systems around here. But the reality is nobody wants to spend $20 downtown the first hour that you go into that parking structure, right? And so there's a lot of issues that the fundamentals speak that the health systems are going to push back, but they're the losers, I think, in the end.
So is Northwestern Memorial Health System a record store?
I'm not going that far. That's a little too provocative for me. But I will say, they to their credit, their leadership has always been able to navigate and adapt, and I've seen others do that. But I think at minimum, the model has to change. Their model is going to have to transition, not just Northwestern. I mean, any health system, their model is going to have to change, because the reality is it's going to be hard to convince consumers that they need to come to those outpatient facilities, with a few exceptions. You're starting to see that. So my former colleagues at Highmark in Pittsburgh, it's one of the reasons why, and you saw, anybody in healthcare saw what was happening with UPMC and Highmark and Allegheny in that environment. And they decided to set up all these satellite community hospitals that are very streamlined, almost like focused factories out into the neighborhood setting, because they thought the centralized model wasn't going to be successful. And so it's much more about a decentralized model. And you can imagine with telehealth, it's taking that decentralized model to the nth degree and just saying, we can go beyond decentralized. We can actually take it to the home setting.
So just skip the facility it's altogether and go directly to the home.
Yeah, and you're going to see some other things that's interesting. So we'll be a little provocative too, because for example, with 5G coming, right? And so there's a lot of discussions about latencies and things of that nature that suddenly won't happen. Well, some of my friends similar to yours, I'm sure, do robotic surgery as an example. And right now the rules was that you have to be next door because maybe there are some issues that are occurring. But the reality is there's nothing, particularly with 5G, once that comes on board, there's nothing that really requires you to come into that facility as a physician. You can do the robotics if it's secured lines. You can do it from any location that allows for that to occur. So you can start to see other provocative ways in which we're going to be able to even undergo surgery and things of that nature with the technology that's coming. And that seems pretty far-fetched. That seems pretty, sci-fi, that the physician could literally be at home. She could be at home performing robotic surgery and have the necessarily staff that's in the operating room there for any unanticipated events. But otherwise, there's no need to be there. And so you're going to see a lot of technology, I think, the next 5 years that allow for us to go well beyond just talking about the things that we're seeing with telehealth.
So I'm going to take a minute. So data to date on robotic surgery has been mixed at best. Is that the technology is not good, or are we going to see something fundamentally different in the future?
You're saying that it depends on what we're talking about now, because what made me pause was, are you talking about in terms of the market reaction to that? Because I think the market's overwhelmed, been supportive. If you're talking about patient experience, I think you're going to continue to see growth on that particular side. So some of my friends that are, again, this is anecdotal, but some of them that are doing robotics find that the patients are pretty pleased with the approach to the surgery and how fast they're healing as it relates to that. Now, what it does require us to continue to be able to do is to be able to make certain that we're doing our patient selection in the right way. And where we saw a lot of issues was related to provider selection as well, making certain that the providers that are trying to do robotic surgery are properly trained to be able to do robotic surgery. But having said that, I was using that as an example of where we're going to be going in the next few years with technology in terms of being provocative. So I think telehealth platform is not as provocative as what I just illustrated related to robotic surgery.
So you're bullish on digital health. What are your concerns about digital health?
It's a fundamentally different model at the end of the day. So traditionally, our model for the most part, and it still remains this way, and I'm not saying it's a wrong model, is that we as the physicians or the clinicians are the experts, right? Because we, after all, went through all that training. We have the student loans to prove it, right? So we're the experts, right? So we're the experts on this. But what you're starting to see is that as we're starting to talk about personalization of healthcare, then you really are trying to allow for that individual to become the expert, and you're starting to be able to push for the individual to be the expert for his or her condition, and for him to be supportive of that. In order to do that, a couple of things I think are critically important that makes me a little concerned about it, and it's not on the technology side at all. It's much more about the culture shifts that's required for that to occur, because it's just a fundamentally different approach to how we think about healthcare, to allow for much more self-care and allow for that patient autonomy to be stronger. And then the health literacy component of how we actually do the digital health, and are we doing it in such a way that we're making certain that the health literacy aspects of what's required to be able to manage that meets the reality of where the average American is. Other than that, I think we're in pretty good shape to be able to continue to see the growth on digital health.
So health literacy and culture, there's this digital divide. Are you most concerned about people who are not as well versed with these digital tools and them being left behind as healthcare goes more and more digital?
Right, and complications, because you may misapply or misunderstand how to use it, right? And so you have to make certain that we're providing technology in a way that and so for some of our colleagues that are listening, understand this, but forcing functions and the design structure of the technology that we're providing makes it a little bit foolproof, so that the individuals are doing the right thing on their own behalf, and recognizing if someone is going to make mistakes, that we've built into the design the most common mistakes that an individual will make, so that we can protect them from those particular issues. So that's where I see the health literacy coming in, is that if we don't properly structure, like take something like diabetes, where we're talking about time and range, right, with January AI. We spend a lot of time at January AI saying, well, what is the reality about how you should structure the instructions for something that's called time and range, when the average American is just not used to looking at charts. They don't spend their days looking at charts, and most of them don't experience that on a routine basis. And so what is the simplest design that would make certain that they understand the reason why it's critically important to be able to do that? Are the ways in which to gamify that in a way that's consistent with how they experience other consumer products? And so Jerry AI and I are talking about, well, what's the gamification way of doing this? So it's similar to the way that consumer products are designed, that it makes it relatively simple for them to be able to access the information without them feeling like they have to become their own diabetes educator, as an example. And then the culture shift has always been a big issue, as you are well aware, in healthcare. Back in the days now, right, this is pre-COVID, back in the days when you used to have national conferences, right? So I used to ask individuals, and oftentimes it would be us doctors and nurses, and I would say, okay, first of all, if you're a physician in the room, raise your hand if you ever had a grade or a promotion based upon how well your team performed, right? And most physicians didn't raise their hand. Very few would raise their hand. And then I would ask the nurses, and the majority of the nurses raised their hands. So we fundamentally, traditionally, I know it's evolved now in the last 5 years, but we traditionally have much more of the expert being this individualized clinician or physician that had all the expertise. And now this culture, as we're moving to digital health, is just not the technology that's shifting, it's that culture that's shifting, where the patient is suddenly having information in her own hands, and they're still going to ask the expert questions, but they're fundamentally the ones that's ultimately supposed to have the autonomy related to the decision we want them to make, and that's a big culture shift.
So before we get to questions from our listeners, we want them to come in. Trent doesn't hold back. I want to switch to who. So you spent most of your career working for payers, insurers, who've generally been slow to embrace telehealth, who've been decidedly bearish on telehealth. Why is that?
I think the primary issue, and for now, I'm gonna assume that you're right, right? So we don't have to get into debates about whether they were slow or not. So I'm gonna move beyond that. Just let's assume that you're correct, right? So you and I can keep being pleasant with each other and not get into debates whether I agree or disagree with that, right? So I think if you think about that, part of the issues is just being very practical about how do you operationalize it. So less about whether or not we think it's a good thing for consumers, because I think most people thought it was a good thing for consumers. But you immediately ran into issues of, hey, providers are saying, well, if you're going to pay for that, whatever you're calling this telehealth, then either you're going to pay me more for the in-person visit, or you're going to have to pay me for these things that I used to do for free from their perspective that now I'm going to call telehealth. So all those phone calls I do at the end of my day after I've rounded in the hospital and I check up on patients and things of that nature, isn't that telehealth? So you had a lot of just practical issues that you had to overcome to be able to understand that. Traditionally, you had network credentialing, like what providers are in your network and how do you credential the providers and how do you structure that? And so you had to work through those particular issues as well. You had to work through issues of, okay, if they're only taking care of the acute, do they actually have the capacity to be able to refer, and do they have a referral network? As we all know, we would talk about continuum of care and trying to make certain that as individuals are receiving care, that it's not just episodic, that we're doing in a way that individual practitioners understand the full care continuum so they can help that individual beyond their particular episode. And so there's questions about where does the telehealth provider link into that overall structure so that we're not suddenly creating more fragmentation. So even if you were traditionally bullish on telehealth, there are just real operational concerns that were practical that we needed to move through. Now, having said all that, I think there are some other dynamics that we could have been much more accelerating. You see, when COVID comes along, we suddenly realize there's a bigger opportunity to take advantage of telehealth than we previously thought was there.
Let me push you. Is it all, from the payer's perspective, all about decreasing utilization of healthcare services and thus decreasing healthcare expenditure?
No. I think one of the biggest things that made us pretty excited about it from the beginning was the consumer engagement and the high engagement with consumers, because when you start talking about medication adherence rates, or you talk about other aspects that consumers care about and that we as clinicians want to see them be successful about, there were a lot of opportunities that we thought telehealth might be able to allow. As you well know, even like on the physician side, and I'm talking primary care, which is one of the reasons why, because when we were doing transportation, depending upon the primary care practice, anywhere from 10% to, for some practices, up to 20% had no-show rates on a daily basis. Anywhere from, if they're really good, they got it down to single digits, but for the most part, they had double-digit no-show rates. Well, those no-show rates in our world is meaning that someone is not taking care of prevention, someone's not taking care of themselves in terms of healthy lifestyles that we otherwise think could lead to better health outcomes. And keep in mind where we're going as well. The reason why, because you mentioned utilization, is majority of payers now are moving as fast as they can with providers into an arrangement that really shifts the risk, a lot of the risk to the providers under value-based arrangements, to the extent that those providers can accept that risk. Now they're not going to do it if the providers aren't ready or able to accept the risk, but to the extent that they are able to have the right infrastructure and accept that risk, then it's less about utilization in a traditional sense and more about appropriateness of care and how do you support the appropriateness of care. So I think telehealth was, yes, it's a straightforward value proposition to a large employer account about decreasing utilization in the ER visits. So all of that is a value prop on the beginning, but that wasn't the sole concern on the payer side. It was much more about ultimately the consumer engagement and how do we make certain that this aligns with the best health outcomes.
So isn't the shift to moving risk to payers dead? I mean, to providers dead? MGHs lose $1 to $2 billion in revenue this year. Cleveland Clinic's margins are down. I mean, are large medical centers really?
But most of that is fee for service, right? So some of that is the reason why. So when I talked earlier about one of the companies that I'm working with for underserved areas, Clinicify, part of that is, and you're seeing this in Blue Cross and Blue Shield of North Carolina, right, with Accelerate to Value, right? And a lot of that work there is about saying, hey, if you were in a value-based arrangement, you wouldn't have been so dependent upon individuals having to show up to your clinic for you to actually receive revenue for that year. So it's less about generating RVUs, resource value units, as we traditionally have done. It's much more about, hey, if I can pay you on a per member per month basis upfront for that month, and you manage the resources that you think is appropriate for that individual, then your financial stability is better, right? So you're not rushing around trying to figure out, are you going to have working capital for the next 30 days because you know it's there. And so I think it's actually going to accelerate, not decelerate.
So let me push you on the private insurers. The profits of some insurers like Anthem, Humana, United Health Group have doubled in the midst of the largest healthcare challenge in a century. Profits doubled in the setting of a pandemic. Do they embrace telehealth even after COVID-19 hopefully stabilizes?
The short answer is yes. I'm not certain that I would link their profits to whether or not they accelerate or adopt telehealth, but the short answer is yes. I think telehealth, and you're saying that the Medicare is continuing to make certain that they're going to continue to, for now they call it relax the rules related to telehealth. Eventually, I think there's going to have some legislation that makes some of those changes permanent, so you're not worried about those particular issues. And when that occurs, I think you're going to see the same with the commercial side, or you might see the commercial side go ahead and make those particular changes, because that's where members are. Members, for some exceptions, because I will say there are some physicians, and this is the question you asked me earlier about, can we just jump on a Zoom call? Some physicians are struggling with the reality of saying, hey, I used to be able to know how to run my clinic in the office. I'm not certain that I know how to necessarily do all of that virtually, and so I need some support, some structure, and things of that nature. So we're going through that type of transition, and so we don't want necessarily have patients or members to have bad experience, and they have to be the ones that suffer the cost of that transition. And so we're looking for ways to be able to, across the board, to support that. But their profits, I don't think, is going to have any detrimental effect on telehealth.
Will insurers pay the same as they do for in-person care?
That is an interesting question, and I'd be surprised starting out that that's the case. Over time, it might be dependent upon what type of arrangement we're talking about. And I mean by that is, are we talking fee-for-service versus value-based arrangement? If we're talking about value-based arrangement, particularly as a lot of the telehealth providers or digital health providers are starting to take on chronic conditions and thinking about longitudinal approaches, and thinking about relationships with traditional providers that may not be considered digital health providers, then I think those value-based arrangements allow for those type of payment models. Traditional fee-for-service, I think you're going to be hard-pressed to be able to say that it's probably the exact same E&M, but I think those are battles that will be decided in the next few years.
All right, I could go on, but we'll have questions. Harry,
okay.
Harry Kawanter wants to know, if the patient becomes more responsible for their health care, how will the payers and lawyers accept the associated decreased responsibility of physicians for outcomes?
How will the physicians and the lawyers?
Payers and the lawyers. If patients play a larger role in their health, clinicians presumably play less of a role. If outcomes are worse, how do payers and lawyers view those outcomes?
It depends on what we're talking about, because the baseline is that might assume that the physicians and the lawyers are accepting the outcomes right now, that they're responsible for the outcomes right now. And you could argue that's not even true right now, right? So, which in fact, I would make that to be the case, that that's not true now. So I probably disagree with the underlying premise there. Having said that, I think they're going to be fine. I don't think this is a situation where we're saying that patients are necessarily assuming more risk than that they're assuming right now, to be honest. And I gave the example of the type 2 diabetic. The type 2 diabetic, for the most part, is accepting a lot of the risk. In fact, it was one of the things that I think when I was at CMS and I started to see how nurses were reacting to some of the safety issues that we were suggesting, we're not requiring because that wasn't a regulation. You'd have a type 2 diabetic come in who's been taking care of themselves, giving themselves type 2, but on insulin dependent, right? coming in, been giving themselves insulin at home, fine. Get into the hospital setting, they're no longer allowed, obviously, to be able to give themselves insulin because everything has to be documented and charted. So the nurses are giving the insulin. But you got to have two nurses now so that there's not a safety issue. So suddenly, something that patients could easily do at home and they're doing really well, it takes the patient and two nurses to be able to give that one insulin shot. That's some of the unintended consequences of the way that we talk about protecting risk in healthcare. So I think it's a good question. I think there's going to be some edge cases, like on the margin, where we always say in law, you know, bad facts make bad law. So I'm sure we're going to have some margin cases that are going to be along those lines. But for the most part, I don't think it's going to be dramatically different than the realities about the liability currently.
Clayton Bennis asked, how can companies initiate the culture shift you alluded to in order to be successful in the digital health industry?
So it's funny, I was talking to someone yesterday about this, and we were talking about it in Target Therapeutics and the reality about some of the waste with specialty pharmacy and Target Therapeutics. And at the end of the day, I said it's about making certain that if you have the large employers on your side and their consumers, then I think you're there. Everything else in the middle will come together. If you're pretty confident that you got the employers on your side and you have the consumers on your side, you have the value proposition for both the employers and the consumers, then everything in the middle is going to end up caving and come together. And that's basically what happened with telehealth.
Mary Arzak asked, what advice can you give to early startups as they develop use cases and positive outcomes and are collecting initial key indicators? How can they continue to best gain momentum before revenues?
Great question that's similar to all your guests. I'm enjoying their questions. It depends on what we're talking about, to be honest, in terms of the startup. And the reason why I say that is device, diagnostics, and drugs are different than service or other products to me. What I would suggest, normally the reason why I structured Noality, to be honest, is just because of this question where I said, listen, a lot of them are doing great with technology and they're doing great with being able to go before the VCs and get investment. Where they stumbled to me, which is why we created this venture services firm for Noality, is that they either have issues related to go-to-market strategy, and so they need some suggestions on go-to-market, which market should I go into and where are the opportunities. They might have some modification related to their product strategy because the way that they're positioning their product might not necessarily be the way that a payer thinks about how they would actually decide whether or not to adopt a particular product strategy. Or obviously the network components and who they know and the decision makers, because as you can imagine, it's somewhat opaque to know who the right decision makers are in a particular plan. So I think all three of those are critically important. It depends now. If you're talking about diagnostic devices and drugs, you definitely need outcomes. If you're talking about some of these other products and services, you may need outcomes, but oftentimes if you have the right individual that you're targeting the market, they'd be willing to do pilots with you. And so it's a matter of being able to get the right pilot partner in that situation.
If people want to learn more about Noality or get connected to you, how can they best reach you, Trent?
It's pretty straightforward. So Noality, just the way it's spelled is K-N-O-W, like knowledge. So K-N-O-W-A-L-I-T-Y, so Noality. So it's kind of knowledge plus reality, because that was my idea, is like, hey, we have to have knowledge about the industry, but you have to have enough reality about how it works. And so that's what Noality is a combination of those two terms. And if you just go to the noality.com website, there's a form you can fill out and send me questions, and then I'll respond to those questions, or someone else will if I don't get to you immediately.
So maybe Megan can put noality.com in the chat so our listeners can out to Trent afterwards. Harry has gotten motivated. He's got another question for you. Will insurers telehealth on a platform that they don't designate as preferred? Will this be like formularies for certain drugs?
Wow. I'm not seeing that yet, to be honest. I'm seeing them treated as traditional providers and making decisions about whether a provider is in network or out of network. And so that's what I'm seeing occurring, much more than you being able to say that you're going to be able to create a platform or a network that's not currently credentialed or designated.
Before we wrap up with Trent, I want to highlight next week we have a very special doubleheader on Chet Talks on Tuesday, September 8th at 12 noon Eastern. Maybe Megan will show a slide. We will speak with Dr. Tom Lee. My guess is Trent probably knows Tom quite well. He's one of the country's leading healthcare entrepreneurs. He was previously the CEO of One Medical Group, one of the hottest digital health companies, and is currently the CEO of Galileo, another hot digital health company. His LinkedIn profile says he's also a man of mystery. So to find out why, he'll join us next week. And then in addition to the second half of the doubleheader is part of our UR-UDAL investigator meeting on the future of Parkinson's clinical trials. We'll be speaking with Ann Wasicki, the CEO of 23andMe on Thursday, September 10th at 3:30 p.m. Eastern Time. Tom Lee, CEO of Galileo and former CEO of One Medical on Tuesday at noon Eastern, and Ann Wasicki, the CEO of 23andMe on Thursday at 3:30 p.m. So Trent, I know you'll be joining us for Chet Talks next week. We're also
absolutely. And hey, Ray, and tell when you talk to Ann, ask her about me beating her in jump rope. I beat her in jump rope.
And jump rope. All right. All right. We'll find out more on jump rope. Okay. I love it. So we're 2 months from, that could be a competition for Chet Talks. We're 2 months from national elections. You've seen healthcare from many different perspectives: a physician, attorney, entrepreneur, insurer, federal payer, and digital health company. Can you give us a bold prediction about healthcare for the next 6 months?
What's fortunate about healthcare, so I'm trying to think about bold, but what's fortunate is I've been around now, I guess, because I was in CMS from 2000 through 2006, and then of course with everything else I was doing. The short of it is, as it relates to value-based payments and health outcomes, each administration, whether they've been Republican or a Democrat, have continued to push that. They continue to push towards that acceleration. I see that continue to occurring. And so I don't see any reason for those that are interested in digital health. I see that you can continue to be bullish, but I do think you're going to link it to value-based payments. And so there'll be some new payment methodologies. So I think if there's anything bold, by the time we get to the end of the next administration, you'll definitely see that we're probably somewhere on the order of over 50% of the payments are no longer going to be fee-for-service and going to be in these value-based arrangements.
So you think the march towards digital health and the march towards value-based payments are independent, or both going to happen regardless of the outcomes of the national election?
Yes.
So digital health and value-based payments, the march continues and maybe accelerates regardless of the outcome of the presidential election.
That's correct. Those are the fundamentals that are bigger than who actually happens to occupy 1600 Pennsylvania Avenue. So
let me give you one that might be dependent on the outcome of the election. We previously discussed how COVID-19 has demonstrated the shortcomings of tying health insurance to employment. Number of uninsured, 12 to 15 million unemployed, a lot of people on furlough, so they're keeping their health insurance right now. If those layoffs, temporary layoffs become permanent, they might lose health insurance. Medicare and Medicaid may soon insure half of all Americans. One of your startup companies, or two of them, might be quite busy. Is Medicare for all likely to occur, say, if the Democrats win?
The short answer, I say no. But and here's why: because even the people that talk about Medicare for all are not talking about getting away from Medicare Advantage. So, which means essentially you still have private health insurance driving most of that. And most of the growth in traditional Medicare is even on the Medicare Advantage side. So that's not quite what some people think about in terms of Medicare for all. What I would say in terms of what you just alluded to, I do think there's a third option that hasn't been discussed as broadly that I'm hoping actually, since you're talking to a lot of venture capital and innovative people, which is, I do think there's an opportunity for a non-employer sponsored insurance, right? Where you're no longer saying that it's either government sponsored or it has to be employer sponsored. I think there's a third alternative that says, well, why wouldn't we be able to have a private non-employer sponsored insurance option? And so I think that fits with what a lot of people would have been wanting to take advantage of and continue to move forward. So I think there's a third option that we haven't spent a lot of time discussing that hopefully comes to the forefront here in the next few years.
Isn't that what the Affordable Care Act was supposed to be doing, allowing an individual market for private insurers?
Well, but keep in mind the way that, yes, but keep in mind all the limitations in terms of who actually could benefit from the way that was actually structured and who was designed for. So if you think about, like, if some of these individuals that have just lost their insurance wouldn't necessarily easily qualified for the individual market. And so that wasn't really designed for a lot of them. But if you would have already been able to have a non-employer sponsor that was privately insured, those individuals, in theory at least, wouldn't necessarily have lost their insurance right now, even though that they switched employers or lost their individual employer. So that's the difference in the potential model that I see, is that there's an opportunity still to say, instead of talking about Medicare for all, meaning a government only sponsored, or it has to be employer sponsored, I think there's a third option here.
A third option to address the shortcomings in employer-sponsored health insurance and perhaps the shortcomings in government-sponsored health insurance. Trent, thank you very much for joining us on Chet Talks and all of your work to improve and make us reimagine healthcare. Until next week's double header with Tom, Lee, and Ann Wasicki, the Center for Health and Technology at the University of Rochester. Thanks you for joining us. Thanks very much again, Trent.